Foundations for Evaluation, Differential Diagnosis, and Prognosis. Okay. So the elbow complex. What joints are involved in the elbow complex? What did you say?
Humeroradial.
Humeroradial. Okay, there's one joint. Okay. Proximal radial ulnar. And what's the third one? Humeral-ulnar, okay, ulno-humeral, you could hear it either way. You could hear radio-humeral, you could hear humeral-radial. You can hear ulno-humeral, you can hear humeral-ulnar. They're the same joint. You can hear proximal radial ulnar, that is not the same thing as the distal radial ulnar, right? Okay, so there are two joints between the radius and the ulna, and where they articulate. Okay, so let's start with the radial-humeral. Radial joint. So we have this joint here. I'm going to use the pointers. I've got the pointer. I'm excited about it. All right. So the ball-shaped capitulum of the distal humerus. So does that strike you as convex or concave? Convex. What does that articulate with? The radius. Okay. So what is the radius? Okay. So if the capitulum, okay, is convex, what is the radial head? Concave, right? So in an open chain position, we have a concave radial head moving on a convex capitulum, right? So if we're moving into flexion, what would we expect from an arthrokinematic standpoint? If I'm moving into flexion, this is my left elbow. Okay? I'm moving into flexion. So concave radial head on a convex humerus. What do we have going on arthrokinematically? Okay. So happening in the same direction, right? Okay. So we have a roll and I happening in the same direction. So I heard anterior, I heard superior. I think you typically will hear this in an anterior form, thinking everything is relative to the anatomical position. That really, really starts to play an important role in your understanding when we're talking about the elbow, okay? Because think about this too. If your arm is positioned like this or like this, even if your arm is positioned like this, let's go for this for example. If my arm is an anatomical position, do you all see how this is an anterior roll, anterior glide? We can all agree, right? But do you know that if my arm is positioned like this in pronation, even though I would be pushing that direction to apply an anterior glide, okay, and it looks posterior, right? But it's still an anterior glide because you're naming it in reference to the anatomical position. So in your mind, you've got to be able to convert whatever position you see the arm in into what it would be in the anatomical position. Even though in your mind it may look like you're pushing posterior, it's an anterior glide because we're naming it in relation to the anatomical position. Does that make sense? So the pronation supination of the forearm complex and the elbow sometimes can complicate that a little bit. And we'll review that, but I just want to throw that out there and plant that seed in your mind to just remember everything is named in relation to anatomical position. Okay, so at this radiohumeral joint, we have some flexion, extension. You can get a little bit of pronation, supination. There's the capsular pattern. Flexion limited more than extension, more than supination, more than pronation. Okay? So loose pack position. There are three joints here. And the loose pack and closed pack positions for these three joints are not exactly the same. Okay? So you could be asked, it's not going to be what's the loose pack position of the elbow. It's going to be what's the loose pack position of the radiohumeral joint, or the ulnohumeral joint, or the proximal radial ulnar joint. Okay, and so recognize they're a little bit different. So when we're talking about loose pack of the radiohumeral joint, we're talking about full extension, okay? Not necessarily hyperextension, but full extension, neutral extension, okay? And supination. So I would encourage you too to look at that on the model. Put the humeroradial joint in extension and look there, look at the gapping there, versus looking at the gapping when you're flexed. You see the difference even in the joint spacing there? So that's what we're talking about when we're talking about loose packed. There's much more room for motion here than there is here. Closed packed, loose packed, okay? So closed packed being 90 degrees of flexion and 5 degrees of supination versus full extension, full supination. All right, so that's where the loose pack comes from. With most of our joint mobilization, for testing purposes, we're going to be testing in a loose pack position. That's where we start. Now, when we go to treatment, usually we will treat in loose pack position to begin with. Okay, you may see it loose packed or open packed. Those terms are used synonymously when it comes to this. But sometimes when we treat, we will start there, but we may work toward. You may see some treatment that's happening out of the loose pack position. We usually start in the loose pack position for treatment. All right, ulnar humeral joint. Okay, so now what surfaces are we talking about articulating on one another? Trochlear notch of the ulna. Okay, is that going to be convex or concave? Do you think? Concave. Okay. So what about the humerus? What part of the humerus? What is that? Trochlea, right? The trochlea. It's an hourglass shape. If you look at that on the model, you'll see that. But again, just like in the radiohumeral, thankfully, okay, it is a convex moving on a concave. So when we're talking about ulnohumeral joint, what are we talking about arthrocanatomically? What's going on? With flexion, let's just say with flexion. I'm moving to flexion. Ulnohumeral. What do we have going on? Anterior what? Okay, anterior slide, because and we also have in what? Concave on convex, so we have an anterior roll and an anterior slide happening with flexion. Who can tell me about extension? Posterior roll, posterior glide. Okay, so thankfully, humeral ulnar and ulnohumeral, it's the same mechanics happening there because they're both a concave on a convex in an open kinetic chain. Okay, in an open chain position. Okay. Now, when we weight bear, this goes back to Euro's question earlier. Okay, when I weight bear and now I stabilize the radius or the ulna in this particular instance, and I move the humerus in a closed chain mechanism. Now what do I have? Okay. You have a convex moving on a concave now, right? So convex moving on a concave. So now it's still the same motion happening, but now in relation to the anterior glide of the ulna, we would have a what glide? A posterior glide of what? Of the humerus on the ulna. Okay, so when you are describing these, whether it's in a practical or just you're studying this or you're trying to understand this in your mind, always think about what's moving on what. And again, that goes back to your question. So we'll talk about that more with proximal radial ulnar joint. But what's moving on what? So an open chain, for this particular joint, we have an ulna moving on the humerus, concave on convex. In a closed chain position, we may have the ulna fixed, and then we have a humerus moving on the ulna, and then we have a convex on a concave. Okay? Regardless of what that is, we've got this glide going on. It's just the way we name it depends on which is moving on which. Okay? Does that make sense? Any questions about that? Okay, so at the ulnohumeral joint, capsular pattern, flexion limited more than extension, and that's generally speaking for the elbow, that's the case. Okay? If you see somebody with a capsular pattern, you're typically going to see that flexion is more limited than extension. Okay? We don't have pronation and supination going on so much at the ulnohumeral because we can look at the joint surfaces. Right? This trochlear notch, trochlea, it really is only permitting motion in that sagittal plane. Okay, versus the radial head, there can be some spin with the radial head on the humerus. Okay, so loose packed and ulnohumeral joint. So who recalls what the loose packed position of the radiohumeral joint was? We just talked about it a minute ago. Tell me what it was. Full extension, full supination. Okay, so it's different here. What is it for the ulnohumeral? 70 degrees of elbow flexion, 10 degrees of supination. Everybody put your arm there. Feel it, okay? Hear it, feel it, do it. All right, it's the best way to learn. Okay, so 70 degrees of elbow flexion, 10 degrees of supination. Now I want you to feel in your arm, okay? So kind of feel how you feel like you can flex from there, move from there. Go back to loose packed. Now I want you to take your arm into full pronation. Try the same thing, okay? Just kind of in your mind, try to feel how much motion you got happening. It's a little harder to move at that ulnar humeral joint. Can you feel that? It's not quite as smooth and easy to move there as it is here, okay? Go into full supination. Same thing. So just trying to appreciate what's the loose pack position, what does that mean? Why do we care about it? Okay, so ulnar humeral, 70 degrees elbow flexion, 10 degrees supination versus radial humeral, full extension, full supination. And proximal radial ulnar joint. Okay, what's articulated on what? So my answer to your question, or my question to your question is, are we talking open chain or closed chain? Okay, so I would choose one. So if you say open chain, what is moving on what? Okay. Okay, so I think I hear over there, radius moving on what? The ulna. Okay, so what, versus if you can picture in your mind, put yourself in a closed chain position. What are we talking about orthokinetically? What kind of surface do we, if we're talking radius moving on the ulna in an open chain position, what are we talking about? What's concave, what's convex? Yes, so a convex on concave. So now what do we have going? So if we're talking about, now we have this spin thing going on, right? Pronation, supination, capsular pattern, supination, limited one pronation, loose pack position. This is similar, a little bit more similar to the ulnar humeral joint, okay? But we have loose pack position, we've got 70, everybody do it again, 70 degrees of elbow flexion, approximately 35 degrees of supination, okay? So that is loose pack position of the proximal radial ulnar joint. Of course, we know what muscles are involved in the elbow. We've got our flexors, the elbow, the biceps, brachialis, brachioradialis, triceps, and the anconeus are going to be our extensors. Supinators, we know that biceps is a supinator, which is why we test MSTT in that position. Along with supinator, pronators, we've got pronator teres, pronator quadratus, one inserts at the lateral epicondyle. Okay, the common extensor tendon versus at the medial epicondyle, the medial extensor tendon. All right, RHJ, what's that stand for? Radiohumeral joint. Okay, so this slide is talking about radiohumeral joint. So again, here's the review. We have a convex humerus, we have a concave radius. So the glide and the slide, the roll and the glide slide are happening in the same direction. Okay, so we see that with flexion, anterior roll, anterior slide, extension, posterior roll, posterior slide. All right, UHJ, what's that stand for? Ulnohumeral, okay? So again, convex humerus, convex ulna, also happen in the same direction. So flexion, anterior roll, anterior slide, extension, posterior roll, posterior slide. All right, proximal RUJ, proximal radial ulnar joint. Okay, so what do we have? We have a convex radius moving on a concave ulna. So happening in an opposite direction. Okay, so with pronation, okay, or supination. So if we have pronation, we have a what? We have an anterior, you can kind of picture the roll, okay, kind of a, what do you call that? A counterclockwise roll, but we're going to call it an anterior. Can you envision an anterior spin, kind of an anterior anterior, like this, the posterior part of the radial head is coming anterior as it rolls, or as it spins, okay? So it looks a little different with this joint, but can you envision that? When it does that, on the ulna, take the humerus out of the picture, on the ulna, when it rolls that way, okay, that's what's happening over here. As we spin this way, can you see how the back side's coming forward, but think about what's happening over here. We've got a posterior glide. So if it's rolling anterior, it's gliding posterior. It's in the opposite direction, okay? And then average your norms, flexion, okay, is that 150 degrees or 0 to 150 degrees? 0 to 150 degrees, good. All right, and then extension, full extension, it says 0 degrees. Some people will have some hyperextension. Special test, ligaments, we're gonna do this in the lab. We're gonna look at varus valgus. Okay, we talked a little bit about this earlier, so we've got Cozen's, we've got Maudsley's, Mills test, we've got the medial epicondylitis test, neurological tests, we've got some Tinel's. Remember, all of those special tests in Dutton and Conan on your lab sheet, they're all fair game for a written exam because they're all fair game for the NPTE, okay, so your board exam. But for the purpose of the practical, the ones that have the asterisk by it are the ones that you are going to be responsible to be able to perform before us for the practical exam. But you want to have an understanding of what they all are, what they indicate. Okay. Any questions about the elbow? On the elbow, there is this clinical prediction rules. Okay, it says lab instructor, quick review, and independent review. So I've got that pulled up here. So there are two on there. There's the cervical radiculopathy CPR and the cervical myelopathy CPR. So I just want to real quick look at those with you. So cervical radiculopathy. This website, there should be a link on your syllabus and on that lab sheet. Okay, so you remember the CPRs. These are things that we do. We look at characteristics, clusters, special tests, and we see that certain combinations of these can give us a higher or a lower indication that something may be present. Okay, so with this test, the purpose of this test is to identify patients with neck and arm pain likely to be presenting with cervical radiculopathy based on specific patient characteristics. This CPR is in a derivation stage, okay, so it has not been validated, but they feel like, hey, it looks like these characteristics, there may be something to this, so they're in the validation phase right now. But this is what they're seeing. This is, I think they may refer to this also as Wayner. I think Wayner did this work, a lot of this work, yes. Wayner's cluster or Wayner's combinations. But there's 4 criteria. So a positive upper limb tension test A, which is median nerve distribution. Have you done these yet in neuro? Have you learned upper limb tension test yet? Pretty sure you cover these in neuro, okay? Median nerve, ulnar nerve, and radial nerve tension tests. So you should learn that in neuro, okay? An involved cervical rotation less than 60 degrees. So what that means, if a person is having left-sided neck pain and they are not able to turn their neck at least 60 degrees to that side, then we would say that would be positive. They would have involved cervical rotation less than 60 degrees. Okay? A positive distraction test. Again, this is stuff you learn in, that's a test you learn in spine, but cervical distraction is where they do distractions to the cervical spine, and it relieves the patient's symptoms. So if that relieves their symptoms of arm and neck pain, that would be a positive distraction test. Okay, and then also a positive Sperling's A test. So Sperling's is broken down into a couple different tests, but it basically is looking at compressing the cervical nerve root here. Okay, so the cervical nerve root. So if I was going to do a Sperling test, I may have that patient rotate and side bend and extend in a certain direction to compress the nerve root on this side to see if that reproduces the patient's arm and neck symptoms. Okay, and if it does, that would be a positive test. Okay, so there's a series that we go through with Sperling's. We have them actively do it, passively do it, apply some compression, okay, which is the opposite of taking them here and distracting to try to open up around the nerve root. So if we open up around the nerve root and it relieves symptoms, that's a positive distraction test. If we compress down around the symptoms and it reproduces that patient's symptoms, that's more Sperling's compression, but that's what those tests are. So if you have 2 of those variables present, it's not very likely that that's what the patient actually has. But if you had 4 of those above things present we just talked about, specificity increases to 0.99, okay, post-test probability to 90%. So we're starting to see, that maybe there's something to that. So looking at these things can help us differentiate, because this is your patient. Why do we care about the neck when we're talking about the elbow? Because some of your patients come in with elbow pain that's not coming from their elbow. Okay, maybe it has nothing to do with their ECRB, their ECRL, or things like this, or the fact that they have a stiff joint. You do all that stuff and it's clear, but you notice that, but they're also complaining of some neck pain, or you notice that they're a little stiff here. Maybe we need to look a little higher to see if there's symptoms in their arm or elsewhere. So that's why this CPR is important to you when we're talking about the elbow. Okay. Now the other one is cervical myelopathy. Does anybody know the difference between cervical myelopathy and cervical radiculopathy? Okay. I don't expect you to. You're not probably there in spine yet. But okay, they both are talking about some nerve compression. But when we talk about radiculopathy, and you see that term, it's typically more talking about compression of the nerve root, okay, which can cause arm pain. What else could that cause? We have compression of the nerve root here. Do you know what else that could cause? Pain, but also nerve damage, which could present like weakness, okay, sensory deficits, reflex changes. So I don't know if you've learned that yet in neuro and in spine. It's kind of this all really does fit together. Okay, I know you're learning them in different classes, but it really does all fit together. Your patient who comes in with arm pain and weakness, well, is it because they have some irritated arm tissue, they've got some dysfunction here, they've got some nerve compression here, or is it because they have nerve compression in their neck? That's what we're trying to figure out. So when you see radiculopathy, you're going to think, do you understand the difference between upper motor neuron and lower motor neuron yet? You learned that? Okay. So when I think radiculopathy, I think more of a lower motor neuron. It is peripheral nerve. It is peripheral to the spinal cord. Okay. And we would see, if I had a nerve root compression here, I would see symptoms in that extremity. I would not expect to see leg weakness if my peripheral nerve root was here. Do you know with a lower motor neuron condition if you expect to see increased or decreased reflexes? Decreased, right? So we might see an absent or a diminished reflex on that side. So if we were talking C6 and I checked the brachioradialis and I saw a diminished reflex, I might be suspecting some C6 nerve root involvement. Okay? Versus if they have lateral epicondylitis and I check their reflexes, would I expect to see a change in the reflex? No. Okay, so these are all pieces of the puzzle that as you're doing your subjective, your objective examination, you're putting all these pieces of the puzzle together to figure out what is it going on that's causing your patient's symptoms. Okay? All right, first, so cervical myelopathy, on the other hand, we're thinking more of an upper motor neuron. Okay? So it's more compression of the spinal cord when we're talking about myelopathy. So the central canal, there's some kind of impingement, encroachment that's causing there to be some compression there. And now we may see arm and neck symptoms, but we could see that bilateral. Or maybe we see some leg involvement. Okay, so that's the difference. So cervical myelopathy, and again, you're not necessarily being tested on that specifically in ortho. I'm just trying to help you start connect those dots, make those connections. Okay? I think more upper motor neuron, I think central issues. And that's why we see here with these characteristics, gait deviations, okay? If they have lateral epicondylitis, we're not really expecting gait deviations, except maybe their arm swings a little bit, okay? I guess you could say that, but. So a positive Hoffman's test, have you learned Hoffman's test, an inverted supinator sign, Babinski, any of that ring a bell? Okay, I think you will learn those in neuro, but those are some upper motor neuron signs that can be present, and also age greater than 45. So if we see 4 out of 5 of those characteristics present, okay, we got a real low sensitivity, a real high specificity, 99% post-test probability. This is, I think they also refer to this as Cook's cluster. If you ever see Cook's cluster for cervical myelopathy, yeah, Chad Cook did a lot of that research. It is also in a derivation stage, okay, but those are some criteria. So you've got somebody with arm pain, you're looking at these. Do they have this present, this present, this present, or do they have this present, this present, this present? And then when you get to your evaluation, you can put in there, suggestive of cervical myelopathy. My clinical impression is, that these symptoms are present and that this patient would warrant further evaluation with XYZ. You send that to your physician. But being able to communicate with these, your physicians are going to be aware of some of these things. Okay? Any questions about that? Okay, so that's your 2 CPRs that are most applicable to the elbow region and signs and symptoms in that region.